Good morning, dear colleagues. Today we will talk about the biopsy part of the clinical pathological course, clinical pathology course. We will talk about the method of biopsy, special techniques of the histochemistry in vivo diagnostic of the disease. Biopsy. It's a medical procedure commonly performed by the surgeon. Involves extraction of the samples of cells or tissue for examination to determine the presence or extent of a disease. What about the history? The term biopsy was introduced into the medical terminology in 1879 by the Ernest Berthier. The first diagnostic biopsy in Russia was performed in 1875 by Professor Rudnev. It is possible to make out 3 stages in more than 100 history of the method development. An occasional use of histologic procedure involving living organs and tissue acceptable for the observation and study approximately until the late 19th century. Restricted application of the biopsy until the mid-20th century, and present stage at which the method is widely adopted and its use in a general and total with respect to human organism, not only in oncology but practically in all clinical specialties. Purposes of the biopsy. First of all, we want to know the histological structure of tissue. Histological, cellular. So establishing of the cellular composition of tissue. Next, determination of the volume of the surgical intervention for the oncological disease, to know if the treatment was correct or not, if the resection was enough or not. Indication for a biopsy. Suspicion of the disease, the diagnosis of which cannot be established reliably or fully using another research method in oncology. In gastroenterology and gynecology, also establishing of the features of the course and severity of the lesion in the disease of some organs. Etiology also possible. The procedure for the receipt of biopsy material in a pathomorphological department or laboratory include a lot of main positions. First of all, the material intended for a histological examination should be clearly labeled and accompanied by the direction. Material from the one patient should be placed in a separate container. Fixation is carried out in 10% neutral formalin. In the direction indicates such clinical data as the duration of the disease, what treatment was carried out, the results of previous studies. It is forbidden to divide the material of the diagnostic biopsy into the parts and send them to the different pathological laboratories. After registration, the required number of pieces is cut out of the subject sent for the research. Types of the biopsy. Incisional biopsy. It's a biopsy in which only a sample of the suspicious tissue is cut from the mass, incised, and removed for the purposes of a diagnosis. Doctor must cut out a fragment of pathological tissue with a fragment of surrounding tissue. It's very important, not only pathology. Cone biopsy. It's a subtype of the incisional biopsy, like in a border between the incisional and excisional. What is it? It's more often used for the cervix of the uterus. Remove the piece of tissue which is cylindrical or cone in shape. Cone biopsy often done following the pap smears, Papa Nicolau smears, or colposcopy and the punch biopsy. So if we received histological answer after previous punch biopsy, that's we have cervical intraepithelial neoplasia, second, third degrees, so the gynecologist may resect the part of the cervix of uterus with this lesion, and this type of the biopsy named cone biopsy. Excisional biopsy. It's a medical test in which the whole lesion or mass is removed and tested. Surgical mapping for the excisional biopsy involves identifying of the lesion and of interest and marking the area around the lesion with surgical markers, including an appropriate margin around the lesion to ensure complete removal. The fragment that the surgeon removed must be ellipsoid. The resultant scar should be long and thin, the linear that follow the natural contours of the skin. Fine needle aspiration is the simplest, least invasive test and uses the smallest needles to simply remove cells from the abnormality. With a special syringe, we suck the fluid or fluid-like substance from the cyst or soft tissues like in the thyroid glands or the breast or maybe the pancreatic cyst is possible. So in the diagnostic procedure, we put the needle into the lump under the control of the ultrasound. A core needle biopsy removed not only cells but also a small amount of the surrounding tissue. This provides additional information to assist in the identification of the lesion. Punch biopsy is typically used by dermatologists to sample skin rashes, moles, and other skin lesions. After local anesthetic is injected, a biopsy punch, which is similar in function to a small version of the cookie cutter. It is used to cut out a cylindrical piece of the skin, like this. The opening is typically closed with a suture, small stitches, and heals with a minimal scarring. Punch biopsy may also be performed when removing small tissue sampling from the cervix of uterus. Endoscopical biopsy. It is a very common type of biopsy that is done through endoscope, which is inserted into the body along with sampling instruments. Endoscope allows the physician to visualize the abnormality and guide the sampling. Endoscopic biopsy may be performed of the gastrointestinal tract, alimentary tract endoscopy, urinary bladder cystoscopy, abdominal cavity laparoscopy, joint cavity arthroscopy, mid portion of the chest mediastinoscopy, or trachea and bronchial system laryngoscopy and bronchoscopy, either through the natural body orifice or a small surgical incisions. Gastrointestinal biopsy. Flexible endoscopy enables access to the upper and lower gastrointestinal tract, such as the biopsy of the esophagus, stomach, and duodenum via the mouth and the rectum. Colon and terminal ileum are commonplace. A variety of biopsy instruments, such as biotome, may be introduced through the endoscope and the visualized site biopsy. The double balloon push-pull technique allows visualization and biopsy of the entire gastrointestinal tract. Mid-core biopsy or aspiration of the pancreas may be made through the duodenum or stomach. Trypan bone marrow biopsy. A bone marrow biopsy is employed in the diagnosis of the abnormalities of blood cells when the diagnosis cannot be made from the peripheral blood alone. In malignancies of the blood cells, leukemia, or lymphoma. A bone marrow biopsy is used in staging the disease. The procedure involves taking a core of the trabecular bone using a trypan and then aspirating the material. Dilation and curettage, one of the most popular variants of the biopsy, is procedure to remove tissue from the uterus. Doctors perform dilation and curettage to diagnose and treat certain uterine conditions, such as heavy bleeding or clear the uterine lining after the miscarrying or abortion. Liver biopsy is the most often used when a patient has a focal liver lesion, such as adenoma, hepatocellular carcinoma, cholangiocarcinoma, metastatic lesions, etc. We also may use liver biopsy if we want to make a correct or pathomorphological diagnosis of non-alcoholic fatty liver disease, chronic hepatitis B and C, autoimmune hepatitis, alcoholic liver disease, primary biliary cirrhosis, primary sclerosing cholangitis, hemochromatosis, or Wilson disease. In Wilson disease, with the help of a liver biopsy, clinician may determine the quantitative level of the copper. Biopsies of the lung can be performed in a variety of ways depending on the location. A lung biopsy may be performed using either a closed or an open method. Closed methods are performed through the skin or through the trachea, and open biopsy is performed in the operating room under the general anesthesia. For what we need it? Determine whether a lung mass is malignant or benign. Stage of malignant tumor. Monitor the progression of lung disease. Identify the cause of inflammation in lung. Explain why fluid has collected in lung. Diagnose a lung infection. Prostate biopsy. Include transrectal biopsy and transperineal biopsy, some transurethral biopsy. It's used in the case of the suspicion of the cancer and when we have an increased level of the PSA, prostate-specific antigen. According to time of taking biopsy investigation, it can be divided into planned, about 3 days, from 2 to 5 days, urgent or intraoperative, 20-25 minutes. Urgent biopsy is necessary for establishing of the nature of the disease, determination of the volume of operation. If we have a benign tumor, this volume will be less than in malignant one. Fast morphological investigation is realized due to frozen biopsy, tissue in cryostat, clear painting of slides, and high qualification of pathologies. Sometimes at urgent biopsy it is possible to determine only preliminary conclusion. Final pathological diagnosis is established in the 3rd, 5th day. Histotechnology, the technique of processing the tissue submitted for the histological study until the preparation of the stained section on a glass microscopic slides ready for study is known as histotechnology. And a person specializing in these techniques are known as a histotechnologist. Techniques in pathology. First of all, you know it's a gross pathology with description, light microscopy, which include histopathology, cytology, and autopsy, histochemistry and biochemical method, immunohistochemistry, which is very widespread now, electron microscopy, very deep method, investigation of the ultrastructure of cell cultures, medical microbiology, molecular pathology. Histology involves the preparation of tissue for examination with a microscope. Basic method of histological preparation of tissue. It's fixation in the paraformaldehyde or formalin. Dehydration of the tissue with the using of the alcohol in sending concentration. Embedded tissue in hard medium, wax more often. Section embedded tissue on the microtome. Mount section on the supportive structures, slides, that can be placed on a microscope stage. Usually remove the embedding medium. Staining, more often it's a gematoxylin niacin, maybe some other additional staining. And finally examination tissue with a microscope. Here you can see the main stages of the preparation of the slides. What do we have? When we receive from the surgeon material which was resected from the human body. It may have the clinical details. Size of the specimen must be adequate if the doctor wants to have a whole answers. Proper fixation 10% buffer formalin. On a gross examination, we describe the pieces which we are received, size, shape, color, consistency. We make photos and we cut it if it's neat into the small pieces, 1 to 1 to 0.3 centimeter in size. Three situations may arise when dissection a surgical specimen. It may be necessary to separate each one of its main components in the fresh state, such as in radical dissection. It may be necessary to remove only some components, such as the regional lymph node, and leave the rest of the specimen as a single piece. It may be better to fix the entire specimen as a block. This can be achieved in several ways, depending on the size, shape, and presence or absence of the cavity in the specimen. Here you can see how we may orientate the material. Depending on the orientation, we have other histological picture. On the first one, you can see cross-section of the muscular fibers, and in the lower pictures, longitudinal section. On this picture, I want to show you how to cut the lesions, and we receive the slides which can be put into the cassettes or into the paraffin blocks, and then on the slide we have a clear picture. About taking of the samples also. We take the edges of the lesions first of all with the borders to the normal tissue if it's present. Wall of the cyst. This material, as I said before, might include normal areas. We must avoid necrotic area. We take the whole specimen if it's small. Each material might have a direction and marks. Sometimes we use inches for the inking of the margins. Very often surgeons want to know if the resection was complete or not, adequate or not. So we inking the margin of the section, and under the microscope we can see the inking area. Is it free from the tumor cells or not? If the tumor cells absent in the margin, we talk about negative margin. If it's present, that will be positive margin, and it means that the resection was incomplete. Fixation. Specimen bits are placed in the porous cassettes, not more than 5 mm in thick, and then it fixed in the formalin, 1 mm thickness per 1 hour fixation. Something about 6 hours. Then it's put into the metal board mold and from the cassettes. Fixation. After fixation is replacing aqueous formalin with alcohol in gradual sequence 70, 95, 100 to make way for paraffin. Dehydration takes place. Removal of the alcohol with xylene that will be miscible with the embedding medium paraffin, impregnating with the paraffin. Embedding. Paraffin block with the embedded tissue you can see in this picture. It's neat for the dense consistency of the cutting tissue. Precaution while embedding in the wax. It's possible that the wax is clear or clearing agents. Do not particle must be present. Immediately after tissue embedding, the wax must be rapidly cooled to reduce the wax crystal size. Section. Section of the material and goes by the microtome. Thickness of the pellicles which we receive from the microtome is from 3 to 10 microns, but more often it's about 3-4 microns. Then it's put into the hot water bath and from it we put it into the slide. Traditional histological technique. Tissues are hardened by the replacing water with the paraffin. The tissue is then cut in the microton and thickness varying from the 2 to 25 micrometers thick. From here, the tissue can be mounted on a microscope slide, stained and examined using the light microscope, as I said before. Picking up section. Here you can see the water bath, hot water bath, where present pellicles with the tissue, with the material for investigation. It's floating, and laborant put these thin pellicles with the tissue material onto the slide. This pellicle must be flat, no air bubbles, no stretch or breaks. We may use automated staining or hand staining, but of course in normal laboratory we have the special machines which stain the histological slides. More often used routine hematoxylin eosine staining. Hematoxylin basic, eosine acidic. Nucleus is acidic and cytoplasm is relatively basic. Sometimes we also may use special staining if we need it. Here you can see autostainer. That is a machine which programmed and stain the slides. First, staining technologies. First staining technologies, it's hematoxylin and eosine. The hematoxylin is basic due to that staining acidic components of the cells a blue color, basophilia. Hematoxylin stains the nuclei of the cells and the endoplasmic reticulum of the cytoplasm. Eosine is an acidic dye that stain the basic components of the cells a reddish pink color, acidophilia. Most often, cytoplasm of the cells is stained by eosine. Bone nitric is also stained by eosine. Here also you can see different coloration of the substances. It's all example of the hematoxylin eosine, but in sometimes it may be, if we stain just in hematoxylin, it will only blue. If it's eosine, it's only pink. And combination hematoxylin eosine give us a real normal picture when we can see the connective tissue or cells or fat, nucleus and cytoplasm and intranuclear inclusions. Next, staining techniques. Second, it's a periodic acid sheaf or path reaction. It's stain mucus, basal lamina and glycogen. Third, arsine. It stains elastic fibers a dark brown purple color. Osmic tetroxide. It stains lipids into the dark black color. We use it for the staining of the myelin and myelinated nerves, or lipid droplets in the liver, or steroid secreting cells. Oil residue, also used for the staining of the lipids. It gives the orange or red color for the lipid droplets. Toluene blue, so-called metachromatic stain. It is a blue stain that stains specific components of tissue as purple. This change in staining color is known as metachromasia. Metachromasia is seen in the matrix of the hyaline cartilage or in the granules of the mast cells or in the mucoid swelling. Impregnation. Impregnation by the silvers is widely used for demonstration of the reticular fibers. Histochemistry. Histochemistry is deposition of a chemical reaction products, color or opaque, like pus, stain or other types of specific substances that bind or associate with specific chemical components of the cells, like Sudan 4. Here you can see example of the identification of the lipids in the tissue with the help of the osmic tetroxide. It's a good fixative and excellent stain for the lipids in membranous structures of the vessels. The most prominent staining in the adherent human cells is seen on the lipid droplets, but unfortunately it's very toxic. Here you can see also identification of the lipids in the tissue, but orange-red color it's with the help of Sudan 4 and black it's with the osmic tetroxide. The next position after the staining of slide, we must cover slide for the protection. Before that we have a clearing with the help of xylene and then put the thin glass cover slip to protect the section. Cytopathology. Cytopathology is the study of the cells and diagnosis of the disease. There are a lot of different variants of the receiving of material for the cytological investigation. It may be exfoliative or non-exfoliative variants. According to that, we have exfoliative and non-exfoliative cytology. Exfoliative samples of cells are collected from the normally shedded tissue like epithelium, spatula or brush to enhance collection. Non-exfoliative cells samples collected by the needle with a suction pressure, fine needle aspiration cytology or cytopathology. Here you can see the typical pap smears, which is a variant of the most popular diagnostic procedure of the cervical cancer. We make smears from the cervix of uterus, from the ectocervix, and put this smear to the glass to the cytological investigation. And if the doctor, cytologist, found the atypical cells, so in this case, patient goes for more deep investigation, goes to the histological investigation, so taking a biopsy from the cervix of uterus, from the most dangerous part, and then maybe more deep investigation. The usual surgical pathology report is comprised of 4 major parts. First, history. History contains the essential clinical data, time of description of the gross specimen, such as sex, age of the patient, symptoms, operative finding, and type of operation. If a frozen section had been performed, the information regarding the organ biopsied, the diagnosis given, and names of the pathology who performed this procedure should be included in the part of history. This portion of the report also should list previous biopsy of the same patient, if any had been taken. Second, precise gross description contains the gross description of the specimen. It should indicate how the various specimens were identified or unidentified by the surgeon, and whether they were received fresh or fixed, intact or open. The specimen should be described with a clear description of the gross abnormalities and their location. Size, color, and location of all lesions should be recorded. The weight of the whole specimen and sometimes the weight of the individual organs of the lesions in the specimen should be recorded whenever possible. Some pathologists rightly recommended the contents of a mammary cyst are better described as amber, brownish, greenish, opaque, or white rather than bloodstained, pus, or milky, because the reason for the color of a secretory is often unknown. This sensible advice should be applied to other lesions as well. Pathologists must identify the various sections taken by the unique letters of the English alphabet sequencing, and with a list this identification at the end of the gross description rather than after each specimen. Brief microscopic finding. It's position number 3. This should be short and to the point. The surgeon usually is not to understand in whether the nuclei are cytophilic or basophilic or amphiphilic, but rather that what that means, if anything. If another pathologist is keen on this point, he probably will like to examine this slide himself. We incorporate our diagnostic interpretation, differential diagnosis, and other relevant comments to the microscopic portion of the report. Others prefer to separate this from the polymorphologic description and place them in the section designated comments. 4. Each specimen received should have a separate diagnosis. If practice is to divide each diagnosis into two parts separated by a dash. The first lists the organ, specific site in this organ, and operation. The second gives the morphological diagnosis, like, for example, bone, femur, biopsy, osteosarcoma. This is useful for coding purposes, and again, it provides the reader with all the essential information on that particular specimen in the single entire. Usually, it is used International Classification of the Disease by WHO. Copies of the pathology report are sent to medical records, the treating physician, station or clinic, and the tumor registry. Of the two copies that remain in laboratory, one is used for coding purposes and another is filled and eventually bound. Pathomorphological or pathahistological conclusion in biopsy can be final, preliminary, and descriptive. Final pathahistological conclusion is verification of concrete disease, nosological form, its clinical morphological variant, and duration. Preliminary or previsional conclusion is the result of morphological investigation permitted to restrict disease in a differential diagnosis, like epithelioid cells in granulomas may be found in different diseases like tuberculosis, sarcoidosis, syphilis, etc. It is necessary to continue deep clinical laboratory and functional examination of the patient. In this case, descriptive answer permits to do in conclusion only about pathomorphological process, like exudative inflammation, hyperplastic changes, or necrosis et al. It is connected usually with the incomplete or wrong taking of the tissue for a biopsy, detecting of the clinical examination of the patient. So, all our procedure of the preparing of slide include gross examination with a gross description, fixation, processing, embedding to the paraffin, sectioning into the small pellicles, staining with gematoxylineazine, and mounting. Now we go to some special techniques which also used in pathomorphology but rare. Frozen section. If we want to receive the slides very rapidly, not more than 5 minutes, we may use the frozen section. Freezing acts as embedding agent by forming minute ice crystal within the cells with the help of liquid nitrogen. Special apparatus which make these slides named rheostat. And the section of the frozen material named cryosection. Water-rich tissue are hardened by the freezing and cut frozen. Sections are stained and examined with a light microscope. This technique is much faster than traditional history, 5 minutes with 16 hours, and are used in operations to achieve a quick diagnosis. So we talk about intraoperative diagnosis when the patient under the anesthesia present in the operational table. Cryosection can also be used in immunohistochemistry as freezing tissue does not alter and mask its chemical composition as much as preserving it with the fixative. Electron microscopy. An electron microscope is a microscope that used a beam of accelerated electrons as a source of illumination. Electron microscope use shape magnetic fields to form electron optical lens system that are analogous to the glass lenses of an optical light microscope. Electron microscopes are used to investigate or alter structure of a wide range of biological and inorganic specimens, including microorganisms, cells, large molecules, biopsy samples, metal, crystals. Industrial electron microscopes are often used for quality control and failure analysis. Modern electron microscopes produce electron micrographs using specialized digital cameras and frame gravers to capture the image. For the preparing of the material for electron microscopy, we use glutaraldehyde fixative and the special glass knife to make very thin pellicles of the tissue. Specimen is mounted on the metal grid. There are several types of electron microscopy, but more often we use transmission and scanning electron microscope. Transmission electron microscope. The original form of the electron microscope used the higher voltage electron beam to illuminate the specimen and create an image. The electron beam is produced by the electron gun, commonly fitted with a tungsten filament cathode as the electron source. Scanning electron microscopy. Produce images by the probing the specimen with the focused electron beams that is scanned across a rectangular area of the specimen. Raster scanning. The image displayed by NSM maps the varying intensity of any of the signals into the image in a position corresponding to the position of the beam on the specimen when the signal was generated. Scanning transmission electron microscopy. Rasters a focused incident probe across a specimen that has been thinned to facilitate detection of electrons scattered throughout the specimen. The higher resolution of the transmission electron microscopy is thus possible in STEM. The focusing action and aberration occur before the electron hit the specimen in the stem, but afterward in the TEM. The STEM is use of SEM-like beam rastering simplified annular dark field imaging and after analytical technique, but also means that image data is acquired in a serial rather than in a parallel fashion. Often, TEM can be equipped with the scanning option and then it can function both as a TEM and STEM. Thank you for your attention.